Hi, so today we will be starting with this topic, cysts of orofacial region. So basically what is a cyst? Let's start with the definition. Cyst. Cyst क्या होती है? Cyst is a pathological cavity that may or may not be lined by the epithelium and contains fluid, semi-solid or gaseous material. So basically this is a bone. This is the ramus of the mandible, suppose, and here this will be a cavity present. यहाँ पे bone नहीं होगी. There may be the presence of fluids, fluid, semi-solid और gaseous material. और इसमें epithelium present हो भी सकता है और epithelium might be absent. So this is the definition. Cyst is a pathological cavity that may or may not be lined by the epithelium and contains fluid, semi-solid or gaseous material. A very important 15 marker question. Define a cyst, classify and OKC. So what is a common effect of cysts? Cysts होती हैं, they may cause infection, pathological fracture or neoplasm. So coming on to the classifications, here are these little mnemonics that might help you. Coming to developmental odontogenic cyst, GOOLD. G is for glandular odontogenic cyst. O is for orthokeratinoid cyst. O is for odontogenic keratocyst. L is for lateral periodontal cyst and D is for dentigerous cyst. Similarly, for inflammatory odontogenic cyst, the mnemonic AIR-BP. Apical periodontal cyst, inflammatory collateral cyst. R is for residual cyst, B is for buccal bifurcation cyst, P is for paradental cyst. Coming on to non-odontogenic developmental cysts, globulomaxillary cyst, median palatal cyst, mandibular cyst and nasopalatine duct cyst. The last one, developmental extraosseous cyst. Coming to the mnemonic DNT, nasolabial cyst, thyroglossal duct cyst and dermoid cyst. So once again, odontogenic cysts में we have two types, developmental and inflammatory. Developmental में we have two types, intraosseous and extraosseous. Intraosseous में we will have OKC, OOC, dentigerous, lateral periodontal, glandular. Inflammatory में we will have apical periodontal, inflammatory collateral, residual, radicular, buccal bifurcation. For non-odontogenic cysts, we have two types, intraosseous and extraosseous. For intraosseous, we have mandibular cyst, nasopalatine, globulomaxillary, median palatal. For extraosseous, we will have nasoalveolar, dermoid, thyroglossal. Similarly, for inflammatory cyst, we have aneurysmal bone cyst, ABC, aneurysmal bone cyst. And here we have is miscellaneous, that is Staphne bone cyst. Done. Revise this classification, write it thousands of times and it will help you only then. Coming on to OKC, that is odontogenic keratocyst. So odontogenic keratocyst has a very strange history. First of all, it was named as a cyst. सबसे पहले in 1956 it was named as cyst. But because इसकी recurrence बहुत ज़्यादा थी, it was named as a benign neoplasm in 1967 because of its high recurrence, aggressive behavior, high recurrence. In 2005, it was named as a keratocystic odontogenic tumor. But now again in 2017, it has been reverted back to OKC and is considered as a cyst and not a tumor. So in 1956, it was called as odontogenic keratocyst, a cyst. It was reverted in 1967, considered as a benign neoplasm and named in 2005 as a keratocystic odontogenic tumor. In 2017, it was reverted back to being called a cyst and not a tumor. Why it was called a tumor and not a cyst back then in 2005? Because of its aggressive behavior, recurrence. So coming to the clinical features में it may occur at any age, but basically second to third decade में most common होती है, second to third decade, and it has a male predilection, common in males than in females. Similarly, common in mandible than in maxilla. You will rarely see a cyst clinically in your clinics, basically that is OKC associated with maxilla. Most commonly OKCs are found in mandible, that also third molar area. So you can just make it in the form of a diagram like this for your exams. This is the ramus third molar area. This will be the first commonly affected. So this will be first area, and then second and third molar area, and then we have is the anterior mandible. Maxilla में third molar and cuspid region is seen, but most common it is seen in mandible. Next we have is the symptoms. Symptoms में it is basically very asymptomatic. 50% of cysts are symptomatic before seeking treatment, but basically asymptomatic होती है. That is, sometime a patient comes for the treatment of a particular tooth of mandible and we detect the cyst in the radiographs. So most of the cases are seen like that. It is associated with pain, soft tissue swelling, expansion of bone. अब paresthesia होगा lip and teeth का in this case. Why? Because suppose this, like, let me clear it out first. So suppose this is my mandible and this is the presence of the cyst, और यहाँ पे एक nerve जाती है. This is the inferior alveolar nerve, as you have read it in the anatomy. This is the inferior alveolar nerve. अब ये जो cyst है, this cyst that is growing up, this will disturb the inferior alveolar nerve and hence will lead to paresthesia of the lip and teeth. It is commonly associated with NBCC syndrome, which we will be studying thereafter in the coming lectures. So clinical features are clear. Coming on to the radiographs. One of the most important clinical feature that has been left here is that the growth here occurs in the antero-posterior direction, antero-posteriorly, and this makes it differentiable from a meloblastoma. Then very important viva part is that growth occurs antero-posteriorly, and it is a very important viva question. Makes it differentially diagnosis from a meloblastoma. Done. Coming to the radiograph, here you can see the lining of the OKC like this. Again, third molar area of mandible, most common one. Radiographic appearance is basically it is a large unilocular or multilocular. यहाँ पे it is multilocular, but unilocular can also be seen. Scalloped borders are there. Hollowing out of ramus, hollow out over, that is no bone is present inside. Extension to inferior border and displacement of the adjacent teeth. Severe root resorption is also there. We refer it to oral surgery, and what happens there is that the surgeon brings out a wide bore needle. So this is the cyst. The surgeon brings out a wide bore needle and aspirate the material. अब aspirate करेंगे तो what we will get is a straw colored fluid or thick creamy material. This thick creamy material has the presence of keratin. Keratin in it. Done. Coming to the histological features. So once this aspirate is taken by oral surgery, this is sent into the oral pathology for histological diagnosis. Histopath will diagnose it. So it has a presence of these three are the most important. This is the diagram here. Corrugated parakeratin surface, palisaded basal cell layer, and uniform epithelial 5 to 8 cell thick. So here this is the 5 to 8 cell thick uniform epithelial. And here you can see corrugated parakeratinized layer. These are the parakeratinized cells are present. Done. And this is the palisaded basal cell layer that is present. I hope you are able to get it. You will make a diagram in your file. So सो बेसिकली इट हैज़ द प्रेजेंस ऑफ अ डॉटर सिस्ट. जो ये डॉटर सिस्ट होती हैं दे आर रिस्पॉन्सिबल फॉर द recurrence of OKCs. Then ल्यूमिन कंटेंट्स कोलेस्ट्रॉल प्रेजेंट होगा, हाइलीन बॉडीज होंगी, कैरेटिन होगा, कैरेटिन. डन. सो कमिंग टू इट्स ट्रीटमेंट. ट्रीटमेंट में तीन तरह के ट्रीटमेंट्स होंगे इसके. सर्जिकल एक्सीजन में वी विल हैव इज मार्सुपिलाइजेशन, इन्यूक्लिएशन और इंसिजन decompression. So this is very thin and friable होगी. मार्सुपिलाइजेशन में क्या होता है? So this is the cyst. Swelling is present. यहाँ पे हम इंसिजन देते हैं and we create a kangaroo pouch. Kangaroo pouch create होगा. Kangaroo pouch create होगा तो क्या होगा? That we will let the cystic contents move outside. Suture it from both the sides. That will help to heal the cystic cavity. Enucleation में क्या होता है? So this is the cystic cavity. We remove the entire cyst. Entire cyst को हम remove कर देंगे अलग से. And this is decompression. Treatment is out of scope. Too much treatment नहीं करना है. Only the names to be done: marsupialization, enucleation and decompression. Coming to jaw cyst, basal cell nevus syndrome. Here it's written that it is very high occurring. क्यों? क्योंकि हमारे पास present होती है satellite cyst. जो satellite cyst बच जाती है ना ट्रीटमेंट के टाइम पे, suppose 1 or 2 of the satellite cysts are remaining here, तो they will cause recurrence of the OKC. Then coming to jaw cyst cell basal cell nevus syndrome, so also called as Gordon-Gold's syndrome. क्लासिक ट्रायड है 3 चीज़ों का. इसमें होंगी हमारे पास मल्टीपल OKCs आर प्रेजेंट, बेसल सेल कार्सिनोमा एंड बाइफिड रिब्स और अदर skeletal anomalies. PTCH1 gene mutation, SMO mutation is also responsible. PTCH will be the tumor suppressor gene present. बाकी other features will be classification of facts cerebri, क्लीडोक्रेनियल डिस्प्लेजिया, मैरोटॉक्स लैमी सिंड्रोम, फ्रंटल और बाइपेराइटल बॉसिक. So that's all for today. We will be doing dentigerous cyst, radicular cyst and the other things in the upcoming videos. Follow for more. I hope you understood. You can just comment down any of your doubts and just subscribe, follow. Thank you so much.